to me, because there's going to have to be a lot of sensitivity to local features, right? You're probably going to have to do some text analyses and try to figure out, get open-ended discussions and see if you can find subgroups. So after that, we look at quality of life, remission status. Remission status is robust in differentiating individuals in recovery in terms of a lot of these profiles.
Yeah, I was thinking maybe some of the animal model people could comment on this, because it seems like a particularly difficult aspect to capture, apart from all of the other ones that we already mentioned. Yeah, Marco?
Well, you say that it's very difficult, unfortunately, to explore this subjectivity of our animals. We do explore individual differences. We can work with heterogeneous strain of rats, for example, to recreate some of the heterogeneity that is true in a human population, but we cannot ask a rat how the rat is feeling. So we need to create operational measure for all the individual differences that we want to explore. Any measure that you are thinking of, we need to make sure that there is an outcome, usually behavioral outcome, that we can measure in a way that is objective for us, because otherwise it will get more difficult to interpret.
Susan?
I think, again, a lot of the things that folks are talking about from the human perspective, are very difficult, or wouldn't necessarily work in a rat model, right? You put them in their operant box and give them opportunity to press for substances, they probably will. But I think what we can probably start to model better is thinking about what people are discussing that cause people to either return to drug use or are barriers to treatment. So, we do it best with stressors, but thinking about, I'm just thinking about people don't have stable housing. Well, we could have a situation in our rodents where we give them poor housing conditions and then give them opportunities to use substances after periods of abstinence or something, and see if the poor housing condition causes them to, use more of the drug than not. And, different kinds of, I think, things that come up in people's lives, we could probably operationalize those and then look at how it changes substance use. So maybe that's the way we can do it, versus trying to proactively model recovery going forward. If that makes sense in animals, I think we need to see what are the barriers that occur in people and how can we model each of those barriers in our animals.
Lauren and Mariania, and then Marco. And then I think we'll transition to the next point.
I just wanted to mention, from a clinical research perspective, I would say yes, and right. We need both objective and subjective measures. And that doesn't even just mean, like, what exactly is your income and how do you feel about that? Or do you feel well supported? Do you have resources? But even when we talk about things like neurobiology, cognitive function, there are discrete measures of neuropsychological function that we use to test people's abilities, what is their level of functioning, their executive function, their attention, so forth. But then we also have subjective measures. How do you feel that you're functioning with your attention, your working memory? Are you finding difficulties in your life? And those are really important, because if somebody is, has a mild level of impairment, but it's really significantly affecting what they do in their work and their day-to-day life, that's going to be really impactful to them on their, day-to-day living and their recovery journey. And so I think it's really important to have both of those measures. As much as we have to limit our measures in our research, I think that if we're all doing this research, we can really get at all of the measures that we need to be understanding it from a well-rounded perspective.
Mm-hmm. Yeah. Marinia, and then Marco.
Yeah, I just wanted to, I think, echo a lot of the previous folks who have noted how important it is, or how it depends. But also, I think too, there's different stages of recovery, and acknowledging that there's, any positive change is positive. So from that perspective too, access to clean syringes, right? Like that is a stage of recovery that might come very far, before any thoughts of abstinence or accessing an MOUD. So even any positive change can be considered a step towards that recovery.
Marco? Yes, I agree. Thank you. I didn't mean to cut you off.
Yeah, I think both things are important, and one good example about modeling subjective versus objective in addiction research is the craving studies. In our rats, we have been studying craving very objectively. Instead, in humans, for the longest time, craving was assessed by subjective measure. But now, the work that Yuan are doing, Mohammed is doing, you guys are using more objective measure of craving. And with this objective measure of craving, what we have been finding in our rats is being discovered in human as well. So I think both things are important in certain way. It really depends what is the main question we are trying to achieve for that given topic. But we have a good example that we explore and we are exploring yet. And I think even craving per se is a good example of translation, because we can do this in our rats and it can be done identically in human population. So
I want to turn this. We kind of started talking. Oh, sorry, Mohammed.
Yeah, no, I was just going to say that one small point about this, there is this tension, at least in the craving world, about subjective versus objective understanding of what it is. Craving in itself is a very subjective idea, right? And our tools that we try to look at that we think are associated with, or at least some aspect of craving do not really correlate well with subjective craving. Right, so we have these brain measures, for example, or cognitive measures that could be antecedent to craving. They don't correlate well unless we do a cognitive task and look at, again, go objectively and look at choice behavior, for example. And that's where we see the objective measures of brain being correlated with the subjective assessment, but then objective calculation of that, they correlate well. So there is this disconnect, but I think that, that disconnect adds this very important variance or variability to what we are trying to measure.
Moving to something we've touched on, and it's one of those. I'll just put the question out there. How can we ensure that our models of recovery are not biased? The data that comes in is what builds the model. And what are some of the ways that we can ensure that our models are not biased? I can throw out one, in obtaining community input, for example, in the development of the modeling, and also in the planning on implementation of models, probably, as well as potentially ensuring that as we are developing the models, we have key stakeholders, part of the research team, to take into account things that we would never think about. But any other are expanding on that? Mohammed?
Yeah, we do a lot of our work where we recruit participants from treatment centers. And a lot of times what happens is that we have a majority of individuals who are seeking treatment there and then volunteer in our studies are men. So we have a huge bias in sex differences. So a lot of work that we end up doing, it's very difficult for us to then look at sex differences because we don't have enough individuals to look at these differences. So what we try to do then is to then oversample and do a little bit more, in order to sample more women in the studies. But then that adds more variability, that one group was recruited through means X and Y, and the other group was, recruited X, Y, Z, A, B, C, and D, right? So that adds to the issue of variability. But I guess these methods are needed in order to decrease the bias that we see, at least in treatment centers.
To follow up on that, you mentioned male females, but also what about like race, class, education? I'm gonna throw them all out there, right? Like, sounds like we need to fund a national study. No,
We should.
what about?
No, so thankfully, I mean, we are in New York, and we're in Manhattan. Where we are located is at a cusp of this really high SES to very low SES individuals, as well as from the ethno-racial point of view, where it's very diverse. So it's been less challenging, but I mean, one of the challenges is about consent forms in which language, and do we have it in Spanish, or what about some of the other instruments that we administer as part of our study? Are they translated, validated in Spanish or not? So that's where we see a challenge. But people who can speak English and understand and can provide consent in English mostly, we don't see a lot of issue, at least in our side.
I will say I'm from Illinois, East St. Louis, Illinois. I'm now in the Philadelphia area, and there are some really big, differences between Midwest South, California South to, the Northeast. And so having, large swaths, I mean, maybe we should be sharing protocols. But let me take the panel members and get their opinions. Marco, you're the next square open.
I think you said it, Brenda, because this is the way to avoid bias, by sharing our protocols and let people in other labs, in other part of the world, doing the same experiment. This is the best way to see how reliable everything is. With rodents, once again, in animal models is more difficult, but if you can share your protocol, if you can share your data, and somebody else can replicate what you are doing, I think there will not be a problem of bias, because if you're using the voluntary aspect of things for your animals, so the animal per se will decide what they want to do, and then some other labs will replicate the same thing. That will be a good way to avoid bias. Another way to avoid bias is to let the animal model fail. Like, you have some prediction, you do it, and it doesn't work the way you want it. When we were working on the choice between drug reward and social reward, we had the complete opposite prediction. We couldn't believe the rats were picking social over drug. I mean, we were working towards making the rat picking drug over social, but the rat didn't want to do it. So, and we published what we found, even if that was the opposite of our prediction.
Thank you. Yajan?
So I think this is related to the question of the interest. When we say bias, what factors are related or predictive of the outcome or the recovery? Then are those factors having different distributions between the data we have versus the target population? So that's essentially the question of subgroup heterogeneity identification. So do we have different outcomes across sex, race, education, social economic status, or geography? So first we need to think about the model. Then we see how they are different. We can use other data sets to adjust the difference. So for example, using the HBCD or ABCD, we try to look into the social economic status or the rural urban status and demographic characteristics. But this is not enough. There could be other confounders that bring in the bias. I think we can only do this step by step. At least we have some lower bound of this bias. So I agree the substantive knowledge is important, but using existing data set from the population level to calibrate the data in the analysis can provide us the lower bound of the bias.
I want to remind us, I want to put a pause in for a second, right? That over 70% of people who are recovered did not go through quote unquote traditional, like in-person traditional treatment centers. And it's funny because to me, traditional treatment centers are probably NA and AA, but just kind of the world I came from. But so when people say traditional, I'm like, oh, AA, because they're everywhere across the world and peer support. But we as researchers, I mean, I go to clinics and I get people from treatment centers. So I understand, but that's an easier spot to get people because they're in one spot. Considering that most people have different pathways to recovery, how do we move the field to encompass the majority of people? Okay, put that out there. And John, your hand was up next, so you get this one.
Yeah, I'll connect back to what we were talking about, but also connect to what you were just saying, Brenda. So, I mean, I think on the issues of bias, the first that we all need to do a better job of. I mean, our field in machine learning get criticized for biased models, but I also think we're leading the way to making clear that we can formally assess bias. And if you're doing explanatory models or machine learning models, we can all do that. Do you see differential performance across groups that are experiencing disparities? Because maybe I say that rather than protected groups, because it can depend on what you're looking at as to who the groups are that may, be most vulnerable. But you can look and see if these models work as well in those groups, and that's a way to move towards objectively, determining if your models are biased or not. And then, of course, representation matters when we know that, obviously, if you don't have representation in your data, your models, you can't even assess the bias if you don't get at least minimum representation. And if you only have minimal representation, you can be assured that they're almost assured there will be. Although I'd encourage us to think about bias more broadly. You mentioned, national recruiting. We're because we do mostly sensing, we can do nationwide recruiting. We enroll people across the country, and we're correcting problems with our earlier models with bias with race and ethnicity because we're in the Midwest and we had problems there, and that was part of the reason to go nationwide. But we also wanted to push into rural communities because we know the disparities are really bad there as well. And so that's where I say we have to think carefully about what groups we look for bias within as well. And then I wanted to make one final point, which is, it's not just representation either. And connecting back to Marco's focus on sex, I've always had good representation of men and women in our samples, and nonetheless, our models, at least our models that we developed top down using EMA, perform less well for women because we selected the items based on a literature that studied mostly white men over 30 years for relapse prevention. So, we can have as many women as we want in the sample. If we don't have the questions to feature engineer from that are going to be the issues that predict lapse for women, the models are not going to be able to achieve the same performance. And so it is more than representation. It is, who have we studied, who's on the team, and it's another reason why I'm interested some in bottom-up feature engineering approaches. Yeah. Don't require domain experts, don't require me to look to the literature to say what's important, but instead, if you're working with language, you can start to work from the bottom up and predictions that we're unaware of because they're in individuals we haven't studied well.
Right, and I would like to also caution some papers that we have out, the taking off the shelf for models that we've used in the past, and we think, oh, we can just retrofit them for this new group by using this new group of training data. We found that doesn't work. So you can't just remove the bias that way. Susan, I love this question. Susan.
Yeah, so I just wanted to comment, not only thinking about a lot of these variables and how they, the bias that can be around them, but really thinking about sort of the intersectionality between groups. So I was really struck during the first session with people with lived experiences with the reoccurring themes of you know, the criminal injustice system, and the you know, thinking about a lot of the women we're talking about when they were as parents, right? And they don't want to seek care because of being at risk for their kids being taken away, all of those kinds of things. So I think we could sample women in our study, but if we're not sampling that particular population that's so fearful of participating in a study, I think we can miss a lot of different, you know, like I said, sort of intersectionality between these variables that I think is very important to try to incorporate. In some of the work that we do at our institute, we also do a lot of sort of seed referrals where we're able to maybe get access to those populations. So we have, you know, in a lot of unhoused communities, we'll have, you know, if we can get one person in and then we can get them to start to refer, you know, within their groups, I think that can really help to at least recruit from, you know, certain populations at a larger sample size.
The intersectionality is, thank you for bringing that up. You know, a lot of times traditionally the way we measure intersectionality is like, how do you feel as a woman? How do you feel as Black? How do you feel as that? But by using these data-driven approaches, we're able to model or to kind of to put these intersectionalities together and to see how they work. And I think that I'd like to kind of move to another question about using the importance of incorporating social and environmental variables, like things that we talked about on day one. And I also, you know, even things like coping skills, like especially when you're doing a lot of the digital and you're using stuff in the passive sensing, you know, you can pick up, you know, a person, you know, like their mood, as well as, you know, apps that they're using or places that they go. Some people here are doing some of the location. And what do we, when we think about our measurement and we're thinking about the future, what are we thinking of how to incorporate the environment, how to incorporate some of these social measures? Marinina.
So this,
yeah,
so this is definitely this is definitely something our team has been doing for with collaborators and multidisciplinary folks across so many different places. There's a lot of really phenomenal conceptual frameworks that have already kind of lit part of the way from that. Like Tim Rhodes's risk environment framework has been really phenomenal in that space. And again, to highlight that a lot of these social and environmental variables will be different at different scales. So for a long time, doing a lot of this analysis at county level was the norm. And fortunately, we're finally moving below that because a lot of things change below the county level, you know, even below the zip code level. So there's, I can drop a link later, but like the opioid environment policy scan is a big project that we've been running with as part of one of the NIH programs that includes, I've lost track of how many, but like it's at least like 125, if not more, different distinct social environmental variables at different scales, depending on the level that researchers are studying. So it could be tract level, zip code, county, state, and there'll be an updated version live in about a month. And what we're finding is that individually these, and this is related to one of the questions coming up as well, individually, I mean, sometimes you want to use the individual level measures because they might make sense to a very local analysis where you don't want to know a score of the environment because you're just looking within one city, right? But we're also finding that if you're looking at a much broader level, if you're trying to compare communities across the country, for example, or you have a recruited sample that only includes a couple of zip codes, we've been finding that kind of those more latent analyses, like we also use a lot of machine learning and that sort of thing at the neighborhood regional level. But you can use geodemographic classification techniques that have been around in social science for a lot of time to start to structure how those, it's kind of like a neighborhood level intersectionality of different features. And it's been really fascinating to see what the outcomes have been. But again, I think it's just the beginning of a lot of work in that space over the next decade.
I mean, one of the we kind of do the same thing, and one of the areas that kind of irritates me at the, even being part of the government, right, is a lot of times these environmental measures are like measured every 10 years or they stop. Like we found something with green space and it's like, okay, hasn't been measured in the last 5 to 10 years. And so, I'm using 10-year-old green space. I guess we could probably now use AI and Google and probably map green space ourselves. But that's one of the problems that we have if we're going to try to incorporate some of these social behavioral and environment. I want to do a quick question about, yes, community capital, but community capital, coping, social support. Significant others or in your one's recovery and those types of variables, kind of incorporating those into our models. What are people doing and how are we overcoming any of the barriers to that? Do you feel like there's room for improvement? There's always room for improvement, but what are we thinking? Okay, I can say what I'm doing. We, wait a minute, is this recorded? Yeah, no, it's IRB approved. But one of the things that we have been able to do is we get text messages. Text is our bread and butter, but we get participants' text messages as well as the text messages that they send and receive, but they're anonymized in a special way. And so we can make some of these, social connections throughout periods of their life and doing like a timeline follow back of what was happening at different points and then trying to tie that to the data, like when were you diagnosed with depression or whatever. We asked them like significant things in their life. Any other ways to be able to kind of map the social and the environment and the experiences of people? Yes, Ashley.
I could be wrong about this, but I would say the majority of folks are using measures of recovery capital nowadays. And so that's sort of the go-to. I will say when you talk about the drawbacks is some of them are using the BARC 10. It's a shortened version, but when you look at the 10 items, I think 2 of the items are actually measuring the status of recovery and substance use versus what would be considered recovery capital. It's a shortened version of a longer measure, so it misses some key categories. And if we're talking about sort of individualized journeys and stuff, then you're not going to represent everyone in that. It also was developed using data that was primarily, I think the average age was somewhere in the 40s, maybe, if I remember correctly. It's primarily a white male sample, lots of alcohol use versus other substance use. So lots of drawbacks as far as validation samples, but even some of the longer instruments, validation samples have had similar demographics by and large. So when I'm talking about emerging adults, like even the wording of some of the items doesn't make sense for for emerging adults. Categories don't make sense. Sometimes the response categories are not really making sense to people. And so, sort of basic things around measurement are problematic on those, but it's all, self-report of those characteristics. Does include things like everything from the social capital that you're talking about, the peer, support that they have, what's financial capital, things that are going on in their lives that are supporting their progress and recovery. The other piece is the wording. And so using even like, do you have people in your life who support your recovery? Well, if you're a person who doesn't identify with the term recovery, or if you feel like you're working towards recovery, but you haven't gotten there, or how do you do a baseline measurement of that when you have someone who says I'm not in recovery? And so those are sort of some of the issues that we're coming across with that.
Thank you. And I'm glad I forgot about some of the issues with that measure, and we're getting ready to submit something, and I'm like, check to make sure I'm not using the 10 version. I just thank you.
Yeah, and one other piece related to is we also a group I work with, we have peer supports, and the group of peer supports talk about the BARC 10 very like they don't like it, but I think it's because they're not sort of their experience with using it, they're required to use it, and they're not using it as part of a conversation, which I think a lot of folks out there are using it as part of a conversation with the people they're working with, and that's when it's like it is more successful, because it's really just opening the door for the conversation. So but the peer supports don't really seem to love it that we're working with either. So that was just an interesting, that's in the last month that has come up, and was not something I was anticipating hearing from the peer supports.
Lauren.
Yeah, I would say that I think, I could be wrong, but I think that based on what I've seen, we do need to think of new ways to measure the social networks and social circles that are really close to an individual who's in or seeking recovery. Like I think about family dynamics and how for certain individuals, having someone who's, sort of a like helicopter parent style of I'm going to monitor your recovery and I'm going to hold you accountable, could be really beneficial for some and might not be so beneficial for others. And so not only understanding what individuals are doing around them in their social circles, are they using substances? Are they supportive of their recovery? Are they providing other types of support emotionally? But then what does that look like, and how do these individuals feel about how they're providing that support? And then the second comment that I wanted to make, which is a little removed, but I've heard talked about quite a bit recently, is how to measure the impact of recovery support services on the community. And I think that can be really difficult too, and is something that we need to think through a little further. I don't have all of the answers, but I know some of the issues, right? Like we want to study how recovery community centers are impacting their community. The first set of variables I think that we naturally go to are things that are policy relevant variables, and things like crime, for example. But just because crime is going up in an area doesn't mean that it's because a new recovery community center was implemented in that region, and likely it's not for that purpose, right? It just happens to be a larger correlate of what's happening environmentally and in the social context of things that has nothing to do with the center entering the community. So I think we need to think a little more carefully about how we can measure the true impact of the recovery support services that we're providing to the community, and in a way where we're not setting them up to sort of falsely find that they're not working, because we do know they work. We just need to find better ways to measure them to really show exactly how they're working.
I mean, I'm going to put talk about the importance of having community advisory boards in our research and really integrated in our research, because that would be something I think that we would pick up, or you would hopefully pick up with, that we definitely should.
Yeah.
Must. We are nearing 3:30, which was the end of this session. And I'm kind of looking at my NIDA panelist director.
Thanks so much, Brenda. And thank you all for this incredibly rich conversation. And thank you to all the panelists. Thanks to Brenda and Anna for leading us through this thoughtful discussion. There's a lot to unpack here, and there's more to come, and we'll continue the discussion in a broader discussion, I believe, following the break. I'll pass it to John to take us out on break and tell us what's next. But thank you all once again.
Sure. Yeah, thank you, everyone. This has been fantastic. So let's take a 15-minute break again. The schedule on the website is incorrect. So we'll go from 3:30 to 3:45 on break, and then reconvene at 3:45. We can continue this conversation. We can integrate the conversation from Kelvin and Warren's session, and we can even go back and sort of compare the sort of ideas of what we're talking about measuring to what we heard on the first day, because I think there is a lot of convergence here in terms of those things. But 15 minutes to recaffeinate, and then back at 3:45, and then we can go until we have an hour, but we'll go for as long as people are interested in talking.
Thank you, everyone.
Okay, so again, we'll give everybody a little bit of time to file in, but if you are here, if you could just turn your camera on and wave, and you feel like it, keep it on for the and keep waving the entire time. And then once we get to a couple rows worth of cameras, then we can get started.
We do whatever program officers ask us to do.
That's I've told you this joke before, Mohammed, but the best part about becoming a program officer is all your frenemies become friends. Just everyone is always loves to hear what you have to say now. All right. See, I'll make the announcement again. If you are back, if you can just turn your camera on and wave, then we'll know we're not speaking to an empty room. Okay. Hey, Kayla. All right, so I think the basically there is no goal for the last session here. So if we feel like we have it figured out, then we don't have to stay around forever. But it was really useful on day one to have the sort of time to expand on any of the conversations that that came up in either today or the previous day, and to sort of talk sort of more integratively about what are the main themes that came out of that. So I have, of course, plenty of follow-up questions and that sort of thing. But I also want to give Kelvin and Warren and Anna and Brenda the floor to ask any additional questions or ask any follow-ups, from your sessions, since you guys did such a great job engendering conversation throughout the day. So does any other burning questions that any of our moderators have?
I have one, which is, I was really, really surprised that in our session, there was almost no mention of substance use itself, like measuring substance use itself, or kind of traditional diagnostic variables that you think would define substance use disorder. And it was kind of shocking to me that it wasn't part of the conversation at all, but I almost forgot about it because I thought all of these other factors were super relevant. So I guess, what do we think about that? How do we incorporate substance use or traditional diagnostic measures of substance use disorder in the models of recovery?
Oh, I guess I will call on people. I'll do the calling on part for this one. I will just take the prerogative of the calling on people job to say that yeah, we were joking. This is speaking in a non-official capacity as myself. It's been like this meeting has been an existential crisis like the entire time, because it's like the questions that I was brought up talking about and doing studies of people in treatment and recovery are not the questions that that we've heard anything about in a lot of these. And Kelvin and Warren and Jabe and I were talking about this at the end of last week, and it's just like we don't, these things from a research side, like you said, Anna, we didn't talk about the stuff that we spend all our time talking about in this. So I think that's a very salient signal here. But Brenda, go ahead.
Well, I was going to say some of us researchers, this is what we've been talking about forever, but I digress. One of the things, okay, I studied under Marty Fishbein, Theory of Reason and Action. I followed him from Illinois to Penn. And one of the key things is that we ask people, what are your intentions, right? What do you plan? So maybe the paradigm is to accept that we should ask people to define recovery for themselves and use that as our outcome. And that it's okay, right? Like, and that can be a measure, this kind of idea that maybe it's okay. I believe it is okay to have individualized measures and to let people determine for themselves what those measures are. Because as we talked about, there's going to be profiles, right? They're going to group together, but it's okay. So that would be something that I would think that we should, something to put on the table, this idea that measurement can be different for different people. John?
Yeah, so I'd say we do measure substance use in our lab, and in particular, we're interested in kind of goal and consistent substance use, reflecting the fact that different people have different goals that they're pursuing, I mean, depending on what the drug is and what their own needs are. So we find that to be a useful model to outcome to predict for a couple of reasons. I mean, first, we were talking about, and at least one of the questions in the last panel, I don't know that we got to it very well, was about figuring out when to intervene. And one of the nice things about something like goal and consistent substance use is it does have a crisp onset, and so you can start to model time course on that fairly well because you can measure when it began, for example. We like it because it's part of the constellation of both subjective experiences and behaviors that might come along with someone struggling in their recovery. And it might be one that happens on the earlier end. And so we think of it kind of often as an early warning sign that an individual return to use in someone who's abstinent, or an individual experience of goal inconsistent use to someone who's pursuing less harmful use, in and of itself may not be catastrophic, but it may foreshadow kind of ongoing problems with recovery that may get worse. And so we like it that way. And then I'll say, certainly in the alcohol literature, there's a robust literature around the idea of abstinence violation effects, that knowing when someone engaged in goal and consistent use might be important for intervention in and of itself, because it may be something that triggers further cognition and emotional experiences that itself could lead to a worsening state for the individual. And then finally, lapses back to use in someone who's abstinent in and of itself can be quite harmful for some drugs with respect to overdose and death. And so, I mean, I actually do think that there's a role for measuring use and building models to predict use that way.
Kelvin, you're next. And then
Thanks.
Shelley, Warren, and Warren.
And I like your question because it illustrates in some respects the purpose for this whole workshop, right? In terms of thinking about recovery. And what I need to keep pinching myself to remind myself that what I hear recommendations here, great ideas I hear about here and concepts, is not something I want to release into a study section that's not designed for looking at that. Because if Warren's point about only 15% of the users are single drug, right? And I just got hammered on a recent proposal because I combined cocaine and methamphetamine as stimulants, and so it's like how do one bridge this transition as we try and think about recovery in a different way. And that's what's made me think a lot about the sessions that we've had today. Thanks.
Shelley.
John, I actually have a different question. So if everybody else wants to respond to, I think it was Brenda who asked the first question, then we can come back.
Okay. So keep your hand up and we'll go to everybody else. Warren.
Yeah, so I wanted to get address on this question. So what we look for is identifying people that meet lifetime criteria on DSM, and then we use remission status thereafter.
Lauren.
I just wanted to mention, thinking about what we discussed in day 1 and day 2, and thinking about the concept of recovery, I think what we're really going to need here is an arsenal of holistic measures that allow us to get at the individual domains that are essential components of this umbrella term of recovery. Not all of those measures are going to be relevant to all folks. Some who identify as, so if your population of interest is a group of people who align more with a harm reduction approach and who want to continue to engage in substance use in a less harmful manner, then we need to be prepared to look a little less at substance use as our primary outcome measure and a little more at these other aspects of their quality of life, their well-being, their thriving, flourishing measures. And I think we can get at that if we don't try to define recovery. Recovery can be this broad construct, but in order to measure it, we need all of these different aspects that we heard about over day 1 and day 2. We need the social aspects. We need employment and money. We need to have autonomy and coping mechanisms, and we need to have certain services available to us. But I feel like instead of trying to define a single concept and say, what's the most important measure we need to be measuring? It's what are the broad measures that we should be looking at together to really define this really complex process.
Yeah, Lauren, that really resonates, because I think it was said on day 1 that recovery is, like you said, is idiosyncratic, and it belongs to the individual in recovery, whereas what we're trying to operationalize is not that, identity, as Noel was talking about before, or anything like that. We're trying to operationalize, like you're saying, these measures that are concurrent with that change in identity, right? And so using recovery as the shorthand for what we're talking about is actually it makes it more difficult to pinpoint what we're trying to do, as opposed to less, right? Like we're trying to measure things in service of recovery. We're not trying to measure recovery because it's not for anyone but the individual to, define what recovery is.
Right, and Brenda had mentioned maybe defining our outcomes according to the individual goals, but that can be difficult in research, right? Because we'd have to then get a sample of individuals who have the same goal in order to study them as a group. But what we could have, like an alternative to that, is gathering information on what your goals are and all of these outcomes that we know are relevant to recovery, and looking at the relationships between goals and recovery outcomes and how they vary by goal.
Yeah, at the risk of embarrassing myself in front of the machine learning people, it seems like we're talking about a supervised learning thing when it's really an unsupervised learning thing, right? Like it's not categorical. It's there are features that are going to be emergent based on what we collect.
Yeah.
Tanya.
Yes, I just wanted to mention what I have noticed through our previously day 1 and now it's day 2. We haven't touched upon the regulatory aspect of all this.
Yep.
And what Kelvin was saying, his experience, it may be then through this it will come to light that there is a regulatory aspect to all of this. And that defines a lot of things. And it defines what we actually, why we need a definition. It defines why is that we still are going for a separate singular substance as an indication. And also it will have an impact on what we can operationalize as recovery. And by today, the FDA goes by a singular substance of use. And of course, there is that polysubstance in reality, but then you ask questions, what's your preferred substance? And then your axis 1 is sort of a kind of being cleared. So there are multiple things that we need to discuss, and it's most importantly that we should think about the regulatory aspect.
Yeah, and I think this sort of goes on to Kelvin's point as well about, there's the threading the needle of study sections, and then there's the threading the needle of the regulatory aspect. But I think it's a disservice to ignore. I mean, polysubstance has come up 1,000 times in 2 days, right? And this sort of self-identity thing has come up 1,000 times in 2 days. And so us not acknowledging that, I think, is going to create more challenges. But Noel, as I just sort of teed you up for both of some of those 1,000 mentions of both of those were from you. So what curious to hear your thoughts.
So, and this is really kind of, it's kind of self-promotion, quite honestly. So I have a grant right now to look at, and it may be worth us thinking about, rather than this variable centered approach of like, you got to do this variable to reach whatever. I think maybe a person-centered approach. I'm doing some work with the Clinical Trials Network, some of their some of their already collected data, doing some secondary data analysis, longitudinal latent class modeling, so that we can take some of these, potential indicators or variables or outcomes and, use this person-centered approach where we're clustering people on polysubstance use, or we're clustering people on some of these important things that we know are important, mental health, those kinds of things across time, and being able to, maybe create interventions that way, by understanding certain groups of people in recovery from this person-centered approach, rather than, our reliance kind of on this, one outcome and these variable centered approaches. So just again, a little bit of self-promotion there.
I'll say for the record, I do not have a data set where people only use one substance. I mean, for my data sets of 100 people to 5,000, people are typically, except the huge national ones, they may just use one, but people typically use multiple drugs. And then even if they say they're using one drug, like as we define it as the main drug that brought you in, when you do a urine analysis, there's multiple drugs, either they know it or don't know it, of what's, because the drug supply is not, not very accurate. I don't know. I think it's unrealistic. And study sessions need to change. They need to get better training.
And that's not, I mean, that's on day one, that's not what we heard was, okay, once I, to Anna's original point, right? It wasn't when I stopped using X, life got better. It's life got better. And that's when I knew I did, the idea of like chaotic use as opposed to controlled use, I think is a much different thing than the full abstinence model. And I'm not advocating for one way or the other. Obviously, like we have to do both, right? Like study sections exist for you guys and the FDA exists for all of us. And so it's like, how do I talked with all of you, the moderators, coming in to say, probably do everything all the time, everything everywhere all at once is going to be one of the solutions that comes up. But and nobody disagrees that that's a solution. But what are the things we can do now to move things forward? What are the kinds of ideas to start pursuing that have more construct validity, and how do we provide arenas to support that kind of research as well. Shelley, are we back to you?
We can be.
Okay.
So sort of one thing that I've heard over the past few days is the need for individualizing recovery, and what that means as an identity and as constructs and measurement. And I guess the question is, how do we as a field reconcile the data and the evidence that's needed to support individualized or personalized recovery characterization in treatment? I think addiction field and, compared to some of the mental health disorders, other areas of psychiatry has been a little bit behind in characterizing or distilling large data down to the individual, and a lot of criticism, that we would face that's probably unique from cancer fields or, other fields that deal with diabetes, for example. And so as we've heard this really rich discussion, I come back to this issue of that we're a little bit in an echo chamber. Everyone here cares about recovery, right? We're not some lone clinician out in a community that's providing services. So how do we generate the evidence that's needed to convince others to expand our circle?
Lauren has an answer to that question.
I don't know if I have the answer. I know I've heard, and a lot of this is coming from my personal research and my K award, where I'm trying to link individuals who are undergoing medication treatment to recovery support services, specifically recovery community centers. And what I keep hearing from clinicians, and when I've spoken to them before and after, is, well, we need your randomized controlled trials and we need efficacy shown. And when I ask, well, what is efficacy to you? I don't get an exact answer. I imagine some people are really going to want to see those, reductions in substance use or abstinence. But I think that we need to emphasize and also show clinicians that there are social and environmental aspects that we need to be measuring as well, because they're just as relevant. And I think that there are many clinicians who are aware of this and who do ask about these things. But I think we need to expand on that a little more. So yes, randomized controlled trials, but also I think as we build the research around different treatment models, different recovery support services, things that are important, that the data will get out there, the science will get out there, and we'll be able to educate more clinicians and practitioners on what is available and what does the science show. And as of right now, we are lacking a decent amount of science in different areas that are showing how these things work or where they work. We kind of know how they work based on what's been implemented and what we hear from the community and what we see, but we need to operationalize it and show it scientifically I think for clinicians to really get on board and go, okay, this is something that I'm going to do in my practice. I'm going to be linking people to these services, and it's not only going to benefit the patient, we also need to show how it's going to benefit and impact the clinical systems model. So is this something you can actually implement in your service? If we say it's really important to start measuring quality of life, okay, well, are the scales that we suggest accessible and freely available to clinicians? How long do they take to fill out? Is there going to be a burden on them or the individuals? So I think we need to think of not only about what do we need to show for them to get on board, but also how can we make it easier, more feasible to actually implement these things in practice. If we show that they work, can we help hold their hand in making sure that we can get this to be a part of the model?
So Aaron, I'm not going to put you on the spot if you don't want to be, but since you have your camera on, and this was a big, I was struck in the discussion on day one about applied clinical practice. The issue was not, I wish we knew X and we just need to know X. It was, there were a whole bunch of other constraints that seemed to be guiding what was going on, because this sort of like, is the patient flourishing? I think everyone agrees that's a major measure here, but I'm curious to hear your thoughts, Aaron.
And just to clarify, when I guess because I work in the field more of opioid use disorder and around medication treatment, I'm typically talking about, sorry, when I say clinicians, less so the psychologist and more so primary care practitioners, people who are sort of that first point of access.
Yeah, and I'm not trying to set up, battle royale here. Just the cross-pollination has been fantastic, so I'm trying to engender more of that.
It wasn't clear, John. It was my fault.
John, I think and folks who were with us on Wednesday know, I think there's just a great deal of optimism about where we are. NIH has already put in a lot of funding and infrastructure support behind the issue of recovery and advancing recovery science. That's beginning to take root and take flight, in addition to the work that's been ongoing for 20 years, represented on this call. I think that there is some immediate work that we can do to be better with operationalizing our constructs. I think if we do a better job and do that across the bench sciences and applied clinical practice and peer recovery and in the field practice, if we can operationalize and create a common language, I think that's really going to help. I don't think we've yet set a template for what recovery services is and how it fits on the intervention continuum. But I think we can do that. And I think we can do that in the next 5 years and really entrench that in the way that prevention services are on the continuum and the way that early intervention services are on the continuum. So once recovery services are on the intervention continuum, then those services are going to benefit from all of the legacy the legacy benefits that come from being on the continuum. Can recovery services be subjected to the same standards of efficacy and effectiveness in research? Absolutely, they certainly can. Are those standards going to be tailored to meeting the needs of and the operational parameters of what recovery services are? Absolutely, but that's true of any kind of intervention, right? That's not unique to recovery services. So I would say that. So number one is making sure we're doing the most that we can do to put recovery services on the map, on that continuum, and so that people know when you're in your intervention trajectory, wherever you are, you're always thinking about prevention, early intervention, treatment, recovery. The recovery services are all part of the continuum. Number two, as we talked about, being clear that recovery itself is about the personal journey, right? I don't go to treatment for recovery. I go to treatment for treatment services. I don't go to recovery services for recovery. I go to recovery services for recovery services. Recovery is the journey that I'm on. And it starts in treatment and it starts in prevention and wherever it is that one starts. I think if we're more careful about that, then some of the benefits that we're going to get for this sort of idiographic application of some of these models and some of these techniques, it's just going to be clear. And it's going to encourage people to come to the big tent and stay in the big tent. And when I say folks, I mean stakeholders from across the continuum. And I think that's something that we've learned very well in recovery science that we can bring into mainstream science, which is science is going to advance only to the degree that all the relevant stakeholders are involved in all of the key decisions about the science progressing. And the stakeholders are the persons with lived experience, and the stakeholders are the providers who are providing the recovery services. And the stakeholders are the systems, the payer systems, the reimbursement systems. If those stakeholders are at the table for the science, not just the scientists, science is going to go better, and that's what's going to move this forward in the most efficient way. John, I'm not even sure if I answered your question, but I will stop talking now.
No, even if that wasn't the question, you answered it. Yeah, no, okay. So a couple points to follow up on there. One,
and so I'll do one more thing to answer your question more directly.
Yes, go.
I do think that in the next year, we can come much closer to having a set of recovery vitals that are operationalizable than we are right now. I think we've got a lot of the constructs that are out there. They're within reach. It's not just recovery capital. It has to do with how we're talking about the relation to the substance itself. It's the recovery capital. It's where they are with other indices in their lives. I think we're closer rather than farther. And once we put all our heads together, we get the person from those various different domains of this work all in the same room. I think we can do it. I think we're already doing it. And if we have that a year from now, a set of recovery vitals, then recovery science hits the accelerator and we go from 30 miles an hour to 130 miles an hour very quickly.
And I think those vitals, potentially Tanya and Jabe, to the conversations that we've had about the need for accessible outcomes, those vitals can start playing a more concrete role in that piece from the DTMC perspective, if I'm not speaking for you guys. But Tanya, go ahead.
Recovery vitals seems to be interesting path to take. The crux of the matter for us would be to be able to connect the recovery vitals so they should be sensitive enough to show the correlation between all the components of the decreased or changed drug use with the recovery vitals. So, some work may need to be done to ensure that what we will kind of characterize is sensitive for change, to pick the change. Because the whole issue was like, okay, so I have changed my life. I have I have decreased my drug use, it's now controlled. But what changed in terms of my social functioning? What have changed with my friends? What have changed with my family, with my job? It's an issue there because it seems to be that it's only accessible when you have meta-analytical size studies. And for us drug developers, we need to show it in a smaller size. So we will need to find statistical way to show the change.
Right, and I think the first piece of that is to start talking about what the metric, to Aaron's point and to Lauren's point, the metrics associated with those changes. And to that point, Marco and Susan, Susan had a flight to catch. I don't know if she's still here. But one thing that you guys said in the last session that I thought was really interesting was the pointing out constructs that can sort of span the entire clinical preclinical realm that are relevant here. So like the idea of, if something like housing stability is an issue from from a context standpoint, we can do more to measure those sorts of things, right? So I thought this is an opportunity in this group to talk about, to Aaron's point about like getting the constructs nailed down. What are the kinds of what are the priorities on each list, and which one of those priorities lends itself most to a model that works at an animal level, but more importantly works at multiple levels, right? So not just an animal model, but other things that our colleagues who are doing human research can use as well. So something that clicks all three boxes, is relevant from a recovery standpoint, can be implemented at human side and at an animal side, would be fantastic. But getting more than one of those at a time, I think would go a long way towards coordinating the response here. So I'm curious to hear other ones beyond just the housing one, because I thought that was a really cool idea.
Susan, do you want to start?
No, you can go ahead. I'm good with that.
So as Susan mentioned, there are ways to model these different aspects. Particularly in the lab right now, we are focusing on the social construct of addiction, like what social structure could do to drug reward, drug choices. So we are giving these choices to animals, and they need to pick between drug or social, and then we can change the value of the social construct, because as we were saying, for people, for not everybody, social reward is rewarding. Social interaction not rewarding for everybody. For some people, social interaction could be stressful, could be actually negative. It could increase craving. So we are devalue the aspect of the social interaction to move our animal towards drug choices. Another aspect that we are trying to address, that I was mentioning in the early section today, is this idea of what society is doing to support people with addiction. So in our model, we have one main rat that has to press a lever to interact with another rat. So the other rat pretty much receives social interaction passively. But in reality, in humans, this is not the case. I mean, if we want to interact, this needs to be a reciprocal interaction. So what we are trying to do is to have the partner rat to decide if this interaction is rewarding or not. So the first rat will communicate with the second rat, do you want to interact with me? And then the second rat, the partner rat, needs to complete the chain to interact with this idea of, if people with addiction tend to be isolated, you can imagine that our addicted rat will be isolated from its partner. So at some point during the development of addiction, our social partner will stop to interact, will stop to voluntarily interact with our rats. So as we were saying, there are different ways to model this aspect. I'm sure Susan will have even more to add to those. It's just complicated. It just takes some time, and we are trying to work to address that. And panels like these are extremely critical for us, and I really hope that we will have even more of these opportunities, because I'm learning so much just by having people with real experiences sharing their experience and how they are feeling about addiction, recovery, and abstinence, and all these phases.
Yeah, and I guess I would add, it's funny, I think about those the old studies from the 70s, in the rat park studies, where they actually attempted to have this very, you know, this environment that was a community that rats could choose to take substances or play with other rats or, you know, have sex or do other things. And, you know, we really moved away, I think, from those sort of ethological kinds of studies to very reductionist. I think that was the point around the single substance use versus polysubstance. We needed to really isolate these very specific parts of variables. And only then, you know, there was a big movement to say we could only look at the neurobiology once we really isolated it out to this one little component. And fortunately, I think Marco studies are some great examples of that. We're sort of moving away from this reductionist model and trying to say, okay, let's incorporate environment now. Let's incorporate polysubstance use. Let's expand back out to sort of the messy studies, because humans are messy, and what their substance use and what recovery and what their use looks like is messy. And as people, you know, I've been struck even with the human studies, people are saying, well, even though we are, you know, focusing on opioids, well, we get substance users of all types. Like, you know, even though their measures might be specific to opioids, it's really hard to discount those other experiences. And so, yeah, I think we're starting to do that in our rodent models. I think we still get a lot of pushback in study sections, as people have mentioned, where, oh, you can't model what we see in humans and in animals. And even when we get more complicated, they still say we can't do it. I guess I would just say, from my perspective, we've been trying to model sort of the front end. So we look a lot at consumption patterns. I think we can be better at modeling like human environments, impoverished environments, those kinds of things. I think some of these more abstract, like motivations, you know, I'm struck when I hear that people, you know, that are unhoused talk about, well, they use methamphetamine to stay awake so they can, you know, keep an eye on their stuff, so they can defend their stuff. Like, that's harder for us to operationalize in our rodents. But I think it's, you know, when we're thinking about treatment and recovery, motivations are a huge part of it. So we need to really be thinking about that.
Ashley, yes, I was going to call on you in just a second. Go ahead.
I think what Susan's getting at is like there's the processing. If we can figure out some of the process that underlines the decision making, and then that the process. I mean, I think Warren's, you know, the work he did with delayed discounting is reason. I mean, when I'm doing contingency management, I'm thinking about delayed discounting, right? It's for that particular individual. Like just thinking of it on an individual basis. And so if you can model the process, you don't have to model the whole ecology, but if you can try to break it down to the process that you're trying to model, then maybe that would be a way of having our cake and eating it too.
So I'm going to put Kelvin and Warren on the spot here, because we had that discussion, Ashley, in our sort of pre-meeting last Friday to go over what were the main topics of day one. And one of the things that we were all sort of in violent agreement about was this idea that the decision-making processes, as we tend to talk about them, you know, even reward-based learning, we're looking at it in a more myopic view than maybe is necessary for exactly this reason, right? Like, it's understanding what are these decision-making processes, and building on Marco's point, right? Like, what are the constructs that we can operationalize across multiple levels that we aren't operationalizing right now? It's not Q reactivity. Q reactivity is important, but there are additional things beyond Q reactivity that seem to be salient in the experience of recovery.
And I do want to just say that beyond, you know, even if you came up with a way to measure sort of a complicated, complex, multi-layered decision-making process, getting a review committee on board with that is a whole other ballpark, and that all of us struggle with. So.
Yes. Kelvin, did you have any, like, I know because we've talked about the decision-making piece a bunch, and I can go to Marco.
It's actually, it's spot on, is how do we, and I like the concept that I'm looking through all my squares. Susan, you were mentioning this thing about the kind of getting down to one variable in terms of the reductionist thing, and now trying to expand it back out. It's a similar thing, actually, for these things about how do we broaden this concept about the decision-making process, say whether it's or other processes like cue reactivity into the larger context of, say, different stages of recovery, right? Or the something that I've been really stimulated my interest is some things that Noel's talking about is just like when that transition to beginning recovery kind of thing. How does the decision making, cue reactivity, all these things interrelate to that aspect? But it's a far more complex question, and the way to collect the data is I get brain strain from thinking about it. You know, it's too much. But
can I just respond to that about I mean, I do agree that there's the complexity of humans with the values and the identity, but it does still like it. So you're not. I mean, I don't know rats well, so maybe you can figure out the values of a rat or the identity of a rat. But I mean, I guess if we may not be able to model that, but we can model that when a person holds a value and yet chooses a behavior that doesn't map onto that we can model that process in a simpler way, granted, but you know, in the face of multiple variables, multiple competing demands on that, it's not going to be perfect, but I think there's something in there that can be, until you figure out what the values of the rat community are.
Yeah, it's a goal-directed behavior thing at a much more sort of superordinate or abstract level than a lot of the ways that it has been looked at. Marco.
Yeah, I just wanted to point out, I mean, Susan was putting in the chat, we can totally model this aspect. I mean, we can totally model contingency management in our rats. If you give them a mutually exclusive choice between drug and alternative reward, this is more or less the basis of contingency management. If you keep abstinence, then you are rewarded with alternative incentives. Obviously, to our rats, we cannot give vouchers as we do for human for contingency management, but we can reward them with palatable food. We can reward them with social interaction. So these are things that we could totally do, and we are doing in the laboratory settings. And it's still a lot of things to do, because as Susan was mentioning, it's time to go back a bit and study the behavioral mechanism, because when we think about mechanism, we think about the reward circuit and this and that, but we are forgetting about these basic behavioral mechanisms that are driving those decision making.
Anna.
Well, this is a topic very near and dear to me because I really think about process level, cognitive process level understanding as critical to understanding behavior. And I was just going to add to what Marco said, that we can definitely model different kinds of value functions and preferences and conflicts. We can even make predictions about when people would have conflicts if we have a good model or theory. And we actually do have a lot of good models of decision making for different kinds of variables that people might integrate into their decision, whether it's delay, like in delay discounting, but also uncertainty and positive versus negative outcomes and different things. So I think the value of those kinds of cognitive models is that they can be applied to not only very carefully designed tasks that are built around those models to test them, but also in different kinds of data, like naturalistic data, which many people are doing now, using social media data and looking at how outcomes of posting, influence your future decisions and so on. So it can be applied very broadly, even if we don't have the time or the methods to, on a daily level, study a broad set of decision-making parameters in a given person. But I would argue we could also do that, but that's for another time. So thank you.
We have the group here, so if you guys have all done a lot of time and energy to participate, so please take the opportunity to query the group. Mohammed, go ahead.
Yeah, I would also say that, looking at I mean, I work with brain imaging and different techniques that are more accessible to individuals, to clinics, to people who are outside of clinics, right? I mean, typically our bread and butter is the MRI and the functional MRI, but there are other techniques that are more accessible into the clinics as well as. So for example, we use a lot of the mobile EEG, for example, or the functional near infrared spectroscopy. These are measures that are, takes few minutes, to set up and can be done easily. So when you think about expanding the variable space, brain imaging could also be done in a more scalable way.
Yeah, we had a lot of discussion in our sort of planning stage. We had a lot of discussions about like, are we trying to figure out how to get imaging into recovery? And as the imaging guy, was a strong no, right? Like, because I think there are, every tool has its place, and the conversations in this meeting have really been about the constructs as opposed to the operational details of what tool best lends itself to that construct, right? So, identity, there's a whole bunch of ways to measure that we're not measuring it at this point. Jabe.
Yes, I just want to emphasize about the regulatory issues. Tony just touched base a little bit on that, because I think as our division, we are really looking for get the interventions, therapeutics approved, so this can be used in the clinic, right? However, we always encounter the regulatory difficulty. So of course, I cannot speak on the behalf of FDA. However, we do feel we have a lot of work to do with our FDA colleagues. We need to, we are not trying to educate them, but however, we need to share the data. We need to show the evidence. We need to let them know the social determinants are so important for the recovery. So in that way, we hopefully we also, as a recovery research community, we can provide really quality data to convince them this is the factors they have to be put into consideration when they are approval any therapeutics relevant to drug use and the recovery.
I think that's well said, Jabe. Like, there's things we can do to grease the skids of the challenges that we have from a regulatory standpoint. Yajin.
Yeah, my question is related. Do we have a data like base that covers existing measures about recovery from the different dimensions, or what studies that have been carried on to measure or to model the recovery, so that we can see whether we can address these questions with existing data, or if we need to collect more data, we can identify the gap. I'm just bring this up to ask you guys, like, is there any database we can look into this?
I think that's a really good question. Yeah, like based on what we've talked about over the last 2 days, are there clear places to go to look for that information, or is the absence of that information thing one?
John, the answer is yes. There is a place to go. The Consortium on Addiction Recovery Science has spent the last couple of years putting together a repository of measures and constructs, building on the archive that the Recovery Research Institute has been managing for several years. We've also been in contact with various folks at SAMHSA and the Data Ecosystems Core from HEAL to talk about common constructs and core constructs. So that information can be made available. Now, of course, there are a lot of constructs there, and so there's going to need to be some winnowing, narrowing, combining, and those kinds of things. But we have a starting place.
Mm-hmm. And the good thing about ABC is we have a foundational base in multiple constructs, multiple measures, everything being significant, all that kind of stuff. So that's great. Angela.
Hi, everyone. I haven't said much today because I'm sort of out of my depth in a lot of this discussion. I have noticed that we've lost a lot of our lived experience folks. And I just think that's worth noting. I understand there's some crises and things, but these discussions get deep and complicated, maybe a little bit intimidating. But I was really interested in a lot of, and this is sort of selfish, but Marinia, I'm sorry if I misspelled your name, but you talked so much, and I actually wrote down some things you said about if we're not looking at policy implications, stigma, and access variables and how they differ across communities, where is the path forward? And I feel like we're making good progress in this talk about how to measure behavior change and recovery and define all of that. But that other piece feels even messier and more complex. And I really was interested in, and I'm asking you particularly if you, and I know we'll read the summary, but how do we incorporate that? Because I feel like understanding human behavior and things like that, we're moving towards, but I don't know that we're really talking about what do recovery ecosystems, and I use that word, I mean geographical service networks, what is the impact, and what is the impact of stigma, and is that something we can do, even look at in something like a preclinical model? And that's, I'm way out of my depth here, but I'm really concerned that we may be missing a bit of that dialogue before we close.
I guess I'll just note from my end, there's definitely a lot of folks who are interested in this topic, in this space, who have been like slowly, pushing things out. I think a lot like using theoretically driven models and kind of consensus approaches, there's definitely a lot moving forward on which variables to include at different levels. But so, I mean, I know that my colleague, Dr. Jodry and I, like, we have a grant out, we're waiting for feedback, and other folks are kind of in similar positions to see what will happen moving forward on that. There's a lot of amazing work happening in the health geography and medical geography space, and that also coincides with urban planning and social science. So, in those and some regional economics conferences as well. I've sometimes, I mean, whether or not those groups are up to date with like even the language of addiction, it depends, I've learned. So I feel like there's a huge need for more cross-disciplinary work in that space. And it is really difficult after a certain point because, research gets siloed, even, financially, funding wise. And that sort of thing. But there's definitely a lot moving forward. And I think that there's a really nice complement because in that field, there's so much depth in like different ways to measure in a multidimensional way what therapeutic landscapes, like that's a term that comes up a lot, like what therapeutic landscapes might look like. But those folks will not have access to the individual level behavioral cognitive research that folks here will have, So I think that there's a lot of depth in both approaches. And I mean, the fact that I was asked to come here, I was pretty excited to be able to share what some of the other geographers are doing, but there's a lot more to be done for sure.
Thanks so much. From a public health perspective, I really think so much about the forest, and I know we have to talk about the trees too, but it's just really important to think, I think, at that systems level. So thank you so much.
And I think that was one of, not that we've accomplished it, but that was one of our goals, is to really sort of start identifying the questions to approach at the various levels from the various constituencies in the meeting. So with that, I guess I'll open the floor for any final questions. And not seeing any, I think we're playing with house money at this point. Like this meeting, after the first session, it exceeded all my hopes and dreams, and it kept doing so throughout the other 4 sessions. So I really, on behalf of the planning committee, I want to thank everybody who came to any part of it, who did any piece of it, and we really heard a lot of stuff that, like I said, conversations that have not been had together. They've been, as Brenda was saying, individuals have been speaking about this, but bringing this group together really, I think hopefully led to some cross-pollination and helps us sort of figure out what to do going forward as well. Noel, would you like the last word?
Yeah, so I'm just kind of curious next steps from here. You know, I've
Yeah.
done a couple of these things. I did one recently with SAMHSA, and I've done one with the ONDCP, and it seems like we all get together and kind of have these conversations, and then it's really hard to follow like what
Yeah.
happens afterwards. And so I know there will be a report, but what will the report be used to do? How can we follow up? Like what I guess what kind of impact is this having, and you know, how can we continue to kind of keep this conversation going? Because I hate when we just kind of come together like this, say all kinds of stuff, and then it just feels like, you know, nothing is really accomplished, or we don't really move forward with anything. So I just love to hear your next steps and how you're kind of foreseeing this play out in the future, and what kind of impact this will have at NIDA and some of the other federal partners.
Sure. So speaking in a non-official capacity, of course, as always, I think in terms of the impact, I think one of the things that we've already started talking about is the description of recovery that's been articulated at this meeting is not one that is sort of been widely articulated throughout the institute. And so really getting this information out to folks in the institute, to, you know, in my personal opinion, the session 1 video is required viewing, I think, for everyone who works at NIDA, or you know, and hopefully, I mean, we'll work on the consent, make sure that everyone's comfortable with it, but that's something that I think needs to get out to the field in general, because like as Marco was saying, and as Anna was saying, right, like that way of talking about these processes is not something that our formal training sort of talks about in any way, shape, or form. And then so there's you know, you have my and the rest of the planning committee's assurance that this isn't just the binder that's going to sit on the shelf. Like, we've already started talking about how to make the not just the report, but the videos you know, accessible to everyone who wants to and needs to see them. And the other thing, and I was going to follow up with the wider group over email about this, is, you know, we certainly didn't come into this thinking that there was going to be a consensus definition, although we do have a consensus definition of recovery to a degree, right? It's individual and not definable as a consensus definition. But some sort of perspective or opinion piece talking about the potential for consilience across multiple levels, the constructs that we're looking at from the individual standpoint, from the public health standpoint, from the geographic standpoint, and then the how do we turn those constructs into operationalized versions, right? Like, what are the animal models we can do? What are the cognitive constructs that we can start looking at? If people are interested in something like that, I think that could have a major impact in you know, not only sharing what we've talked about, but also guiding and signaling to the field a direction to go that, you know, prior to this maybe had not been on people's radar because of the other realities that we've talked about, right? Like the study section piece, and the regulatory piece, and the timeline piece, and all that sort of stuff, right? But I think, you know, conveying this information out to the wider community, if people are interested, I think that would be a really good way to go about that, and we can figure out the next steps in doing that as well. I know everyone's busy, but this has just been a really rewarding confluence of ideas, and there's more that people are in agreement about, I think, than people are not in agreement about. Does that start to answer your question, Noel?
Yeah, no, it definitely does. I mean, I think one thing that would really be helpful too is that, you know, I know that, and again, this is like pipe dream kind of stuff, but with, you know, with NIDA especially, I think that it would be helpful if because there's definitely, like, everyone was talking about like reviews, you know, review committees and stuff like that. There's not even a recovery section that some of these studies could even go to. And so I think that it would be really helpful for NIDA kind of to move in that direction, as far as like, I don't know, again, these are kind of pipe dream kinds of things, But and then CPDD too. I mean, just even applying to CPDD, they got treatment, they got prevention. There's no recovery submission for CPDD. I mean, it's just really small things like this that is that are really, I mean, making recovery phase of the continuum of care feel like the stepchild kind of a thing, or just an afterthought to what's really happening in the science. And that's really a kind of a, I don't know, it's not a comfortable place to be.
No, I agree. And I think some of that to a degree is the natural difficulty in defining it. But I think that this meeting has gone to a degree to defining it. And you know, to Aaron's point before about the stuff is around, or we're in a position now where, you know, getting an equal seat at the table is much more operational as opposed to just theoretic at this point. So I hear what you're saying, Nolan, and I know my colleagues here are in agreement with what you're saying as well. Okay, with that, we are at 4:45. Like I said, hopefully this is not the end of this discussion. We've in our back channel have said, you know, we've identified 4 or 5 workshops to have based off of individual parts of this one. And like I said, I'll be in touch with the summary stuff for the meeting, and then and reaching out about gauging interest in some sort of publication or something like that from the group. And then the other stuff we will continue to work on. But I think this is a really strong foundation to build on, to be able to point tangibly, not just to us saying this is what's happening, but now we have, you know, we have it in people's own words, and we have, you know, the places to start addressing these issues. So thank you all very much. And if anything comes up or any questions, please don't hesitate to reach out to anyone who's been involved.
Thank you.
Thanks again.